I'd encourage people to come to the microphones and ask a question. While you're doing that, if we could just have the house lights up a fraction so I can see the microphones, that would be good. So, Director General, I'm going to go easy on your voice, but, you know, is McCaughan right? Is our funding model fundamentally focused too much on just the numbers? How are you going to actually ensure that it delivers better patient care and, importantly, the out-of-hospital care that we need to see integrated within our system?
Yes, Brian's absolutely right that it's funding the volumes through our hospitals is not the end object of the process. However, to work out where we should be putting our resources and to be able to start to use the emerging work of the ACI, the CEC, our approach to data and outcomes, that's a process we've had to go through, certainly in this our first year, and going into next year and extending the process into other areas such as mental health and subacute. That's a necessary sort of housekeeping thing we have to do to make it transparent. The first thing this did was reveal to people where the resources went. And just as Brian was saying, is when that more fine-grained clinical information is fed back and people say, we had no idea, the impact of feeding back the financials to people as to just where the money went, comparative costs against benchmark and so on, you know, is a complete revelation. And so that's been a necessary first step. And what I was trying to emphasise this morning is it's a tool that then provides a very strong platform where I hope we can then start to use this other more sophisticated information about, well, and why I emphasise this being a purchasing model, because where it can take us as system managers in the larger national model which Stephen described, we can start, and we have to have some effective ways of doing this, about how we purchase pancreatic surgery, how we purchase and support incentivised integrated care. So, and I think that's the important thing that we have to understand. This is a tool, we've got to use it. We want to not have people just focus on how can we game it. I think that leads nowhere fast because we're still in a budgeting environment. It's not a reimbursement environment. And as purchasers, we'll move increasingly to look at how to use the model to support the right models of care.
Good, thank you. So the microphones are in the stairwells, so please, if you're standing at a microphone, wave your hands. We do have a question at the front. If I could ask you to introduce yourself, where you're from, and then address your question.
Karen Luxford, I'm Director of Patient-Based Care at the Clinical Excellence Commission. It's been a great first session, thank you. I obviously acknowledge that there are improvements in moving away from historic-based funding to activity, but I think it's fabulous to hear the comments from Brian about are we just really paying for more of the same in a different way. I wanted to hear Stephen's thoughts on the countries that are moving from activity-based funding more towards thinking about patient outcomes and how they're integrating those into their existing funding models. So, for example, the great work that's happening now in the UK at looking at PROMs around patient-reported outcome measures. What are the outcomes from the patient's perspective that we should be paying for and how we're going to integrate those? And then thinking about the American model where we're looking at integrating the quality aspects that Brian raised again, and how are we moving towards integrating the patient's experience, for example, as we've seen in the US.
Thanks, Karen. When you think about funding reform, there are three, or at least three key requirements. The first is technical feasibility, the second is management capacity, and the third is political will. So with activity-based funding, we've had the technical feasibility for decades. The management capacity is variable, but adequate, and the political will nationally occurred over the last couple of years. For moving to more sophisticated purchasing or funding models, for some of them the technical feasibility isn't there at the moment. For some of them, the management capacity isn't there, and if you don't have either of those, you're certainly not going to get the political will. So Karen referred to a number of reforms that are taking place across the world, and by and large, I'm a supporter of moving to what is called normative funding. That is, rather than just reflecting back the average practice, which, as Brian pointed out, is highly variable, you want to actually start to move to a situation where you're reflecting what ought to be rather than what currently is. And if I take the example of a person who wants to do needlework and can't do needlework, what the health system at the moment offers is a cataract operation. And sometimes that cataract helps her do her needlework after the cataract operation, sometimes it doesn't. So the question is, should you make sure you know why the person wants the operation and then measure what she's like now and what she's like afterwards and adjust the funding to take account of, if you're not delivering what the patient wants, why should you pay as much for that care? So, and in the United Kingdom, there's a number of experiments where they do that, called patient-reported outcome measures and so on. And I think that's a really interesting challenge. It may have also helped to reduce the number of unnecessary operations done in this country. Good idea, but still at its very early stages, and I'd put a cross against the technical feasibility for that one. In the United Kingdom, they're also starting, or in England in particular, they're also starting to move towards what I would call clinical pathway pricing. Just say, this is what we think the national standard ought to be in how this care is delivered, and this is what we will pay for. Sometimes it's actually more expensive than average practice. Often it is less expensive than current practice. They might say, for example, why is there such a huge variation in the proportion of patients for this condition admitted on a same-day basis versus not? We are going to pay at the nationals, where we want to think there ought to be in terms of same-day proportion, rather than where it actually is on average. So moving towards clinical pathway pricing, we're closer to that, and I'd put a tick on that. One of the problems in Australia is the legitimacy of the IPA, the Independent Hospital Pricing Authority, can't actually establish the clinical pathways. It has to be someone in a body which is legitimate to actually establish the clinical pathways. A third example might be the situation where at present we pay hospitals who have lots of adverse events more for having those adverse events than we do for hospitals that don't have adverse events. Some might say this is a perverse incentive, and I'm on record of saying I think it's probably a good idea that we don't reward hospitals too much for doing adverse events. And so there are lots of these examples. I think the technology is there. I don't think the management capacity is there, or rather I think that there's too much other things happening on in the health system at the moment. So, we need to look at the phasing of that. So yes, I think there are lots of other models where we could incorporate quality and other initiatives into the funding system. I think we should, and we should do it over time. I wouldn't do them all in one go.
I think we should just lighten the tone after that. I had a patient, like Stephen was mentioning about whether the patient would be able to do needlework after a cataracts. I had a patient ask me if he'd be able to play the piano after I took his lung out. I said, yeah, of course you can. And he said, oh, thank God, I've never been able to. So,
and I think with that example, you see why I part so unkindly referred to Brian as the no-brainer.
So we have a question at the rear microphone.
Yes, good morning. Tony Sara from southeastern Sydney and from ASNOF. Most of us in the audience would support Professor McCaughan's presentation of quality, outcomes, costs being better in all aspects. The driver for those sorts of changes, in my view, and I think the views of many staff specialists, is the department. That is the engine room in a teaching hospital for those sorts of changes. And we do thank the Director General and the Minister for putting an education program for staff specialists, heads of departments later this year. But we can encourage, we can provide education, but unless the culture of that institution, that district, allows for the engagement of those staff specialists to drive the changes that Professor McCaughan has so well demonstrated, then it all doesn't go very far. So my question is to the Director General, How do we
Thank God, I thought
ensure
you were gonna ask me.
that the culture of those institutions, those districts, fully engages those clinicians in those departments, and not just in a few districts, but in every single district? Otherwise, we will not get the system we want, and the colleagues won't have satisfying, productive lives. Mrs. Foley.
So I think that's for you, Mary.
That's right. I keep waiting for the microphone to be passed, and I forget that the clever technology means somebody up there's just switching it on. Look, great question, Tony, and I think it's very important to emphasise that performance framework I referred to very briefly as part of this whole structure goes to the whole range of the things we want in performance, including culture, and culture is a very high priority, as is real, what we're calling, second level of devolution to the individual hospital and department level, supported by appropriate systems and information. So this is an area that we see as an area of accountability. There's lots of ways you build culture. An edict from my office saying, Director General directive, you will have a culture X, won't actually make it happen. However, it does start with leadership, in that leadership has to show that this is important and that we focus on, because everybody responds to wherever the focus goes. And it is something that is always been number one in the Minister's policy framework, and it is fundamental to the conversations and accountabilities that we're having. I think then it goes to a whole series of what practical supports we can provide for that. So there's a push and a pull factor. There's how do you identify and model, best practice. There's a peer competitive factor. So all of those things have to be mobilised to get the sort of deep culture change and support we're talking about. And a day like today is part of that process too.
Nigel.
Yeah, can I just add, I think what you've touched on is the really critical piece of where we need to get to, and we need to support those changes actually happening at the level of the clinical department and the units, and providing information and methods to have clinicians and managers come together at that local level. It is reflected in some of the changes that have occurred in the structure, with investment in organisations to support clinical care, Cancer Institute, Clinical Excellence Commission, the Agency for Clinical Innovation, New South Wales Kids and Families and other. And I think, it's epitomised by a discussion yesterday that we had in the ACI, where we had each of the local health districts from around the state and specialty health networks. They provided a senior clinician and an executive member, somebody from the executive team from each of the districts, to come together and start to talk about what are the local health district priorities. But it was clinicians and managers coming together, and we're modelling that at all different levels in the system to support this sense that we need to work together and come together to have those discussions. And the more we do that from the leadership level, then support those changes happening at the local level, I think the more we're likely to see the improvements in the direction you are keen to see and we're keen to see as well.
Brian, another comment?
Just add quickly, while I support Tony in the industrial sphere he's in, it is not confined to staff specialists. I'm a VMO. Leadership comes from different parts in different settings. Lots of places don't have staff specialists. I come from a hospital where we have one for almost every red cell. I mean, so I'm spoiled, and I recognise that. But other hospitals don't and rely on different levels of clinical staff. This has to be for everyone. It's not an industrial issue. It is about everyone being involved, and that's the sort of breadth of people we have on our ACI and CEC clinical networks and individual programs. So it's not just about staff specialists, while recognising their critical role on site so much of the time during the week.
Thanks. Question down the front.
Thank you. Michelle Adair from Cystic Fibrosis New South Wales. We have 3 marvellous paediatric and 3 equally marvellous adult clinics in New South Wales treating people with CF. There are about 1,100. And a paediatric clinic reasonably recently established in Canberra as well. Can you provide some indication on what the continued development of the funding models will be that might help us work with our hospital and ACI colleagues to alleviate the risk that we're starting to hear, which is when we currently fundraise to take the clinic teams actually to do their regional outreach to alleviate the burden of bringing patients into the city unnecessarily. But we're hearing increasingly that because of the district parochialism sometimes that's emerging, that in fact, although we can cover the cost of taking the medical teams and nursing teams, allied health professionals to the regions, we're starting to hear that because it's not a hospital clinic in my patch, I don't want to fund it. Yeah. And that we're actually having some difficulty in getting, we fear, our clinicians released to actually do that outreach, which does all the sorts of things that we're talking about, keeping people out of the system, keeping them healthier for longer and reducing the burden of their illness.
Can I have a first go?
Nigel.
You're only a CE.
Sorry, Brian. I mean, we've heard enough. I think it's a big issue, and certainly our respiratory network, we're aware that for the first time now in New South Wales, there are more adults living with cystic fibrosis than there are children. So there's a shift now occurring because we're so successful in caring for those people that they're gaining adulthood, which is fantastic. But there's a need now to consider how we actually provide services and care. So our respiratory network is involved in developing a model of care for adults living with cystic fibrosis. And I think the first thing is to actually be clear about how can we best provide care, have consumers involved, clinicians supporting that process and defining the appropriate model, which will include some of the elements you've talked about. It's then the responsibility for us to work out how we support that through the appropriate funding mechanisms. And I think what these changes allow us to do, and some of the reconfiguration, we've got to ensure that the decisions around how things are done still come from the basis of evidence, of best practice, best outcomes for patients, and having consumers and carers involved in deciding what that should look like. And then the funding can be provided to support that. And what we're starting to see is as we get more information about what it costs to provide care in different places, we can build the models and support that with the appropriate purchasing and funding arrangements to ensure that when it is delivered, it's delivered effectively. Now, I think we've still got a long way to go on that, particularly given our lack of knowledge around what it costs to provide care in outpatient and community settings, and the opportunities to start to think about how we provide better care in a primary care sense. That needs collaboration with the Medicare locals and other funders. But I think we've got the building blocks now to start to move in that direction. So I think that the starting point will always be an appropriate model of care, though. So that's why we're involved in doing that work at the moment. Stephen?
Just to supplement more technocratically what Nigel had to say, I was a consultant to the Independent Hospital Pricing Authority in designing the National Activity-Based Funding System. We were very, very clear. The National Health Reform Agreement talks about public hospital services. It doesn't just talk about public hospitals. Public hospital services can be delivered by a number of organisations, not only local hospital districts. They can be delivered in a number of places, not only on hospital premises. So clinics can be run by anybody under contract to a local hospital district. That is, the funding arrangements are site independent and organisation independent, as long as it is a public hospital service and a tertiary non-outpatient clinic. Whoever provides it sounds to me like a public hospital service. So it could be funded under these arrangements.
Nigel?
I really strongly believe we need to move very quickly away from talking about public hospitals all the time in relation to funding services. I mean, we've got to start to get a dialogue around, what happens in a community setting, what happens in an outpatient setting, what happens offside of hospitals. We've got a great system in New South Wales of local health districts providing services in community settings, in homes. And the quicker we can start to change the language, I think it's going to support the direction we need to go in. I'm not to criticise, what's been said, but we're still focused, and the language is still around hospitals.
I agree with all that. I agree with all that, but unfortunately, the term, it is a useful distinction. Public hospital services are not just what happens on public hospital premises, and that's really, really important.
So I think you're in furious agreement about the need to step outside the hospital space and the ability to do that in the funding arrangements. Director General, it's a critical issue though. In our devolved governance structure, there are incentives for LHDs to put up barriers around the boundaries of their LHDs and only do what they see as relevant for their local population. Is that what's intended in the governance model? How are you going to address that?
Well, absolutely, it's not what's intended, and And certainly with each of the districts and networks getting established, we did find some of that tendency. So we're very conscious, I'm talking about districts in the we, we're very conscious that that's one of the risks of the devolved governance model. And so again, we need to, in multiple ways, make sure we've got other things that push in the other direction. Some of those are cultural, some of those are accountability requirements, specific purchasing. The role of the pillars are absolutely critical here. The pillars in their role are looking system-wide all the time and have a very particular role in this model, which I think is very important, in that the pillars are able to range across that picture and to be able to bring people together and then to design the models. So again, this is about, nobody has, Stephen was outlining, nowhere anywhere in the world has yet designed how you effectively purchase in this broader, more integrated space. And I think it's open for us in New South Wales. We've got some very good pieces of the picture and some very good initiatives, and it's open to us to be able to design it. One of the issues is to name it. So it's great to have from the consumer side, the patient side, saying they're experiencing this in a particular area, and it's one where we all have to grapple with that. So it's not meant to be a whole set of separate domains. We are one integrated state service, and it's a great integrated state service.
I'd like you to join me in thanking our panellists from this morning.